Okay, so let's get started. I welcome you to the International Toronto ACG Rounds, and it's my great pleasure to introduce Dr. Robin Ducas, who is the medical director of the Manitoba Adult Congenital Heart Disease Program, Manitoba, in Winnipeg. And Dr. Ducas spent 3 years in Toronto from 2015 to 2018. She did a 2-year fellowship in ASHD first, and then continued her training in Toronto by doing an echo fellowship. So Robin, welcome, and we are looking forward to your management and follow-up of aortic coarctation.
Thank you very much. All right, so I'm going to jump into this. I have no relevant disclosures, but I will say that aortic coarctation I like aortic coarctation as much as the next ACHD physician, but it's not a particular area of interest. So I was asked to speak about the follow-up of this condition, and I think it would be very helpful because it was a good exercise for me to go through the literature and get an idea about why the recommendations we have are the way they are. So the objectives of this talk, first, we're going to discuss the guideline indications for intervention and coarctation, specifically reintervention, but it's the same for native coarctation intervention as well as recoarctation. We will discuss the recommended follow-up and surveillance for patients with aortic coarctation. We will review the role of exercise testing in aortic coarctation. And at the end of this lecture, hopefully you'll be able to discuss the role and indications for screening for intracranial aneurysms in patients that have aortic coarctation. So when discussing aortic coarctation, it's important to realize that it is a part of a generalized aortopathy. It's not a discrete lesion and everything else is fine in the body. And we typically describe it as a narrowing of the aorta, usually at the level of the ductus. It could be preductal, ductal, or postductal, but in general, we usually describe it as being juxtaductal. So there's two main forms that we have. The first being a discrete form of aortic coarctation, typically, as I mentioned, juxtaductal. And we'll usually see this just distal to the left subclavian artery, as you can see in this diagram here. There is also forms that are a lot more diffuse, where you can see in the diagram that's on the screen now on the right side that there is a larger area of narrowed aorta. Again, it's going to be typically in that juxtaductal region, distal to the left subclavian artery. Now, when looking into this, I thought it was interesting to go over the historical perspectives because the journey, like many of the congenital heart lesions, has varied over the year. And the first clinical description of if we get you to mute your mic, please.
Everybody mute their microphones. Sheila.
All right, thank you. So the first description, or at least one of the first description, was actually by Morgani, who was a well-known Italian physician who was able to start characterizing clinical pathology or clinical presentations with autopsy findings. And so prior to his time, a lot of the medicine was felt to be problems with balances of humors and issues having imbalanced humors. Whereas Morgani was able to look at patients' presentations and clinical descriptions of how they were doing and correlate that with autopsy findings. And so in 1761, he published a very well-known series of letters and books describing these findings. And his description of aortic coarctation was actually interesting. It was a 30-year-old shoemaker who presented to the hospital with shortness of breath and chest pain and subsequently died. After autopsy, it was revealed that he had significant LVH. They described his heart being twice the size of a normal heart, very thickened, and a very unusually small descending aorta. He compared it to an aorta of a small woman that he would not have expected to have found in such a large man. But it wasn't really until much later that medicine was able to do anything about these lesions. So throughout history, there were many other pathologic descriptions of coarctation after Morgani. But it took until 1944 a doctor in Sweden by the name of Dr. Crawford, who actually attempted the first surgical repair. And one of the issues surrounding that is there was a lot of concern about cross-clamping the aorta and causing paralysis. But in this particular case, there was an 11-year-old boy that had severe upper limb hypertension. And Dr. Crawford did an end-to-end anastomosis with a 2-hour cross-clamp of the aorta, and the child actually did well initially. Fast forward then to 1982, this was the first time that a percutaneous intervention was attempted on patients with aortic coarctation. And it was actually done as a bailout. Dr. Singer performed a balloon angioplasty in a newborn a few days after surgical aortic coarctation was unsuccessful. So that began more work on balloon dilation as a treatment for aortic coarctation. And then in 1991, it was Dr. O'Loughlin did the first stent implantation. And again, this was a bailout type of procedure. It was done in a 12-year-old boy that had previously had aortic balloon angioplasty, resulting in aortic dissection. So we go all the way from the first clinical descriptions to the first surgical attempt, then to percutaneous interventions. And with respect to management of aortic coarctation, a lot of the care these patients received prior to today was in fixing the initial lesion. Whereas I think it's fair to say that in 2022 and moving forward, we're really looking at how to take these patients beyond just intervention and care for them over the course of their lifetime. And so just to get a little bit more into what coarctation is and where it falls in our grand scheme of congenital heart disease, it is considered a lesion of moderate complexity when it's in isolation. However, it is not usually in isolation. When we look at the diseases, so this is just out of the AHA guidelines, looking at classification of the lesions. You can see the moderate category in the center there. We've got coarctation along other congenital lesions similar to ostium primum defects, AVSD, and tetralogy of Fallot. But it is frequently associated with other lesions, which can make coarctation itself a lot more complicated to care for. And so when we divide up isolated coarctation, that usually makes up about 20%, maybe a little bit lower, of all patients that have aortic coarctation, with 80% having some additional lesion, be it either a bicuspid valve, a ventricular septal defect, TGA, or univentricular heart. And so if we look at the demographics of patients with aortic coarctation, we can see that it accounts for anywhere between 5 to 8% of all adult congenital heart patients. The number will vary depending on where you look in the literature. In general, the live birth rates are approximately 1 in 2,500 live births. And there is a clear male predominance for this particular lesion. It's reported to be about 2 to 1 in most series of patients with aortic coarctation. Usually there's about 60% male patients. The genetics are not well described in aortic coarctation, but there is some associated Notch1 genetic abnormalities that may be seen in patients that have aortic coarctation, although it's not routinely tested for. Now, with respect to pathogenesis, there's 3 prevailing theories about why patients develop aortic coarctation. The first is that there could be tissue from the ductus that gets incorporated into the aortic wall, which can result in coarctation or narrowing and constriction of that area of the aorta after birth. The second theory is that during fetal life, there's reduced flow in that area. So you have a narrowed isthmus at the left subclavian or at the ductus. And after birth, due to that reduced flow, it doesn't continue to sufficiently grow. So you get a narrowing. And lastly, there is some theory that you can have abnormal involution of small segments of the dorsal aorta. So in this diagram, you can see here a normal structure where you have your aortic arches, and the arch here that becomes the right subclavian will have normal area of involution, whereas in some patients there's a hypothesis that you have an abnormal area in the descending aorta, and as after birth this progresses on to an area that has involution and coarctation. So 3 main theories. Now, these patients can present in very many different ways at very many different ages, and a lot of that is because the signs and symptoms of the clinical presentation will really depend on the severity of aortic coarctation. We know that upper limb hypertension is the most common presenting symptom in adults. And typically we will ask about or assess for other associated symptoms, including headaches, nosebleeds, dizziness, shortness of breath, abdominal angina, and claudication. But the presence of those associated symptoms is not universal, and will, as I mentioned, will depend on the severity and duration of aortic coarctation. So when we're talking about following up these patients, physical exam is an integral part of our clinical assessment. But I think it's important to say that the physical exam will depend on the vascular anatomy, and when in doubt, do forelimb blood pressure. So what I mean by this is I've shown here in this diagram 3 different versions of an aortic coarctation. There are more variants, but we're just going to discuss these 3. You can see in panel A here, you've got a patient with an aortic coarctation that's postductal, and the great vessels, so the right subclavian and the left subclavian artery, all come off proximal to the area of coarctation. So clinically, this patient would have upper limb hypertension in both right and left arms. In another variant of aortic coarctation, there could be a preductal coarctation, and you can see in this diagram here in B that the left subclavian artery comes off distal to the level of coarctation. In this patient in panel B, they would have right arm hypertension, and the left arm may be normotensive or low because of the coarctation that happens prior to the level of the left subclavian artery. And in panel C here, this patient has an aberrant right subclavian artery, which is present in about 5% of patients with coarctation. And you can, hope you can appreciate that the coarctation is proximal to the right subclavian artery takeoff. And so in patient panel C would present with left arm hypertension and may have normotensive pressures in the right arm, which would be incorrect. So I think when caring for these patients, it is important to note that although the guidelines say check a right arm blood pressure, really we should be clear about what the vascular anatomy is. And this is also quite important after patients have intervention, as some of the interventions may disrupt the blood flow connection between the right or left subclavian arteries, and sometimes both, to the aorta. In physical exam, we do look for weak femoral pulses and significant coarctations, and upper limb to femoral pulse delay. So either brachial femoral delay or radial femoral delay can be seen. Murmurs can be auscultated, although they're not pathognomonic of it. We can hear a systolic murmur in patients with coarctation from the area of stenosis, which may be heard typically in on the back. And a continuous murmur can also be auscultated in patients that have very large or prominent collateral vessels. Now, when examining patients and following them, it is important to understand there are frequently associated lesions. So when we're talking about isolated coarctation, that is the only abnormality the patient have, is that narrowing in the aorta. So that would be our simple coarcs. For complex coarctations, those are patients with bicuspid valves or VSDs, transposition, Schoen complex, hypoplastic left heart. There's a large spectrum of the lesions they can have. But just, I'd like to go over some of the common associated lesions and conditions. So bicuspid valve is quite frequent. In the literature, it will vary the percentage of patients with a coarc that have bicuspid valve, but it's upwards of around 80%. There is association with other left-sided obstruction. So that's the sub or supravalvular aortic stenosis and patients with Schoen complex. These patients may go on to develop aortic aneurysms, which can be seen in about 6% of patients. And as I mentioned, you can have right subclavian artery anomalies in about 5%. And intracranial aneurysms that have been described in the 10% range. And we'll talk about this a little bit later on in the lecture. Important to keep in mind as well is that certain genetic syndromes have association with aortic coarctation, including Turner's and Williams syndrome. So with respect to long-term complications as clinicians that we're going to be looking out for, it really will depend on if they're repaired or unrepaired. In general, we're going to be managing repaired patients, but I will cover some of the unrepaired complications. So for patients that have unrepaired coarctation, they have a very increased risk of death. So about 25% mortality at 20 years and about 50% mortality at 30 years in patients that are unrepaired. And this is older data. But at the time, the thought was that life expectancy was about 35 years in this patient population. Patients may present in unrepaired coarctation with left ventricular failure, intracranial hemorrhage, or evidence of aortic dissection. For patients that are repaired, there's a very high prevalence of hypertension in this group. It does range in the literature, but it probably will depend on how long you follow them for. But anywhere between 60 to 80%. They do have early mortality. Recoarctation is a common complication and does vary depending on the group of the literature that you're looking at, anywhere between 10 to 34%. Some groups say it's even higher than that. Aneurysm formation after intervention is also a complication that needs to be watched out for. Dissection and other cardiovascular events like myocardial infarction or stroke. And so I'd like to discuss the indications for intervention, and I've broken it down into recommendations from the American Heart Association, the European Society of Cardiology, and the Canadian Cardiovascular Society. They're in no particular order, but we will go through the different indications. And so for patients that either have native or recoarctation, the American Heart Association recommends intervention in patients that are hypertensive and have a catheter gradient, so on angiography, of greater than 20 millimeters of mercury, or this could be done through echocardiography. They also need to have, or they also could have a catheter gradient of 10 millimeters of mercury in the setting of significant LV dysfunction, significant aortic insufficiency, or large collateral vessels. And they do make a comment of having appropriate anatomic factors, so sufficient amount of coarctation to cause those gradients, presumably. The European Society of Cardiology has similar recommendations where they recommend intervention on coarctation in patients that are hypertensive with a catheter gradient of greater than 20 millimeters of mercury, or a greater than 50% narrowing of the aorta on imaging. What's also interesting is in the most recent ESC guidelines, they recommend intervention on patients who are normotensive that have a catheter gradient of greater than 20 millimeters of mercury, or evidence of a 50% narrowing of the aorta on imaging, which is something that the other two guidelines don't specifically comment on. For the most recent Canadian Cardiovascular Society guidelines, again, they're focusing on patients with the presence of hypertension, a catheter gradient greater than 20 millimeters of mercury, or evidence of a 50% narrowing of the aorta on imaging. So there are similarities between the three groups, but some noted differences. And when we talk about repair types that we would either be sending our patients for intervention or managing our patients post-intervention, the majority of repair types done in younger children are typically surgical, whereas in older patients, we're typically going to be seeing more percutaneous intervention. But just to give everybody an idea of the lesions that we may be dealing with, the first described surgery, and one of the more common one, is the end-to-end anastomosis. In more recent years, it's an extended end-to-end anastomosis where there's a larger excision of tissue to help reduce the potential for recoarctation. Patients may also have a left subclavian flap type repair. And it's important to understand and remember that these patients will have disruption of the vascular supply to the left arm typically. So blood pressure should not be checked in that arm or should not be followed in that arm. And this needs to be communicated to their primary care provider. Patients may have a patch type of repair where tissue is used to patch the area, material is used to patch the area of coarctation. Some patients may require an interposition or a tube graft, and then there's bypass grafting in severe areas of coarctation. So these are some of the surgical interventions in patients that you might be following. As I mentioned earlier, that in most adult patients, intervention is typically recommended by stent, but it all does depend on the anatomic factors of the patient. So there are long-term complications that you can have despite any type of intervention. For the surgical type of repair, we can see recoarctation, aneurysm formation, pseudoaneurysm formation. For stents, similar findings. We can see patients that develop recoarcs. They can have stent fractures, which may cause problems long-term as well. Aneurysm formation is possible, as well as pseudoaneurysm. And this can be seen in the acute setting as well as in the long-term setting. So they do need ongoing follow-up, and we'll talk about that. So when we look at, well, what type of intervention should be performed? So when we're following these people, what are we going to be recommending they undergo if they do develop a recoarctation? The guidelines have sort of an interesting take on things. The American Heart Association recommends either surgical or catheter-based repair, depending on anatomic factors. They really don't say one's better than another, but leave that in the hands of the care providers. They do mention that balloon angioplasty can be performed if the patient isn't appropriate for stent or surgery. So balloon angioplasty would not be the preferred intervention. It would either be surgical or catheter-based. The ESC recommends catheter-covered stent as the preferred treatment for patients with coarctation, and balloon angioplasty really only having a role in patients for redilation of a previously placed stent. In the most recent CCS guidelines, they recommend that in patients with discrete aortic coarctations, that transcatheter approaches are preferred. And in patients that have long or tubular and narrowings or arch involvement, that a surgical intervention is preferred. So it seems that either intervention may be appropriate depending on patients' anatomic factors, and this is where a multidisciplinary discussion is typically very helpful. Now, a lot of the recommendations for intervention are going to be based off of imaging findings. And what is interesting is that there is agreement between all three guidelines to say that the preferred imaging modality for surveillance is cardiac MRI or CT when that's not possible. And I think it's important to have a minute to discuss the role of echocardiography in coarctation and the limitations of echocardiography in coarctation. So echocardiography is typically used as a screening tool when evaluating patients with coarctations. It's good for identifying patients that have LVH, which we'll talk about a little bit later on in the talk, and how that's a very helpful finding because it does have prognostic implications. Echo is great for assessing the valves, very commonly used to assess bicuspid valve and other lesions the patient may have. What echo is not reliable for is Doppler gradients through the coarctation. The echocardiography can underestimate gradients in the presence of extensive collaterals. It can also underestimate gradients if Doppler alignment is not optimal. In addition, after repair, echocardiography may overestimate gradients if there's a long area of intervention or tubular narrowing. And so this is an example here of a patient of mine that has a significant aortic coarctation on clinical exam, a significant difference in arm and limb blood and lower limb blood pressure. However, his transthoracic echo only demonstrates a modest flow velocity in the descending thoracic aorta. As you can see here, it's around 1 meter per second. But because of large collaterals, that's part of the reason why we're not seeing a very high gradient. Another patient of mine has had stenting done in an area of previous surgical repair. And as you can see here, this is another suprasternal notch view, the descending thoracic aorta. The flow velocity through her aorta is quite high. It's about 3 meters per second, but no clear diastolic tail or no prominent diastolic tail. And so this is an overestimation of the gradient due primarily to her longer repair site and stent. And she has no blood pressure or a catheter-based gradient across the coarctation when we evaluated. What echocardiography is good for, though, is Doppler of a diastolic tail. So if you do a pulse wave Doppler or continuous wave Doppler, as the first panel here shows, and it shows clear evidence of antegrade diastolic flow, that can be helpful in identifying evidence of a significant residual coarctation. So the panel here on the left side of the screen shows the suprasternal notch view. You can see there is antegrade diastolic flow in that sawtooth pattern. And the panel on the right side here shows a pulse wave of the abdominal aorta with evidence of antegrade diastolic flow. So just there and there we can see. So those are helpful findings on echoes. So if you are interpreting those echoes or reading reports, those are things that would give you a clue that there's a significant cohort. Now, to give you just an example of why we can underestimate things on echo, this is one of my patients who had a coarctation stent. And as you can appreciate on the, I will go back, on fast view, that the alignment of our Doppler continuous wave or pulse wave would be very challenging in her, as on the en-face view on the left side of the screen and the lateral view on the right side of the screen, the stent itself is in a position that would be very challenging to line up with the acoustic windows we typically get on echo. So that would be one reason why you may underestimate the gradients on echo. So some key imaging recommendations, looking at imaging of the thoracic aorta. To remember that TEE is limited in detecting gradients, but helpful with that antegrade diastolic flow. So that's transthoracic echo is limited for evaluating gradients, but helpful if you see antegrade diastolic flow in the aorta. Transesophageal echo, I didn't get into any images. It is limited because of the angles, so it's not an optimal imaging modality for coarctation. Whereas the recommendation is typically to perform CT or MRI. MRI and CT are best for the site anatomy, evaluation of obstruction, and collaterals. MR can quantify gradients and collateral flow, and both modalities can be useful to differentiate high flow on the echo. So if the echo demonstrates high flow in the descending thoracic aorta, CT and MRI can be used to differentiate that high flow from true obstruction. And so when we look at, well, what's the recommended follow-up? I've taken this out of the American Heart Association guidelines and gone through the physiologic stages that they recommend tailoring our follow-up to. So for physiologic stage A, B, and C, I've provided sort of a Coles Notes version of what a coarct patient may have to be part of that group. And for patients that are normotensive, they recommend outpatient follow-up every 24 months, every 2 years. For patients that have either hypertension or some mild abnormal findings, the follow-up's similar. When we're getting into patients that have concern for recoarctation or other symptoms, the follow-up intervals decrease. And again, that's also decreased intervals for transthoracic echo, CT or MRI, and exercise testing. And then in quite ill patients, you can see the intervals are even smaller. But what is interesting is that the Americans do recommend follow-up with transthoracic echo, follow-up with some type of cross-sectional imaging, as well as exercise testing in this group. The Europeans aren't quite as prescriptive, but they do recommend that outpatient congenital heart follow-up should happen every 12 months for these patients, with interval follow-up imaging by CT or MRI, similar to the Americans at that 36 to 60-month interval. So when we're following up these patients, we do need to perform our physical exam. We'll be looking for blood pressure. We'll be looking at our cardiac exam. We are recommended to use echo as a screening tool to evaluate the presence of LVH, that antegrade diastolic flow in the aorta, which can be helpful when evaluating for recoarctation. Coarct gradient, as I mentioned, there's caveats. If it's present, you can look into it further. If it's absent, that doesn't mean the patient has no coarctation. But cardiac MRI and CT are our preferred imaging modality when evaluating the site of coarctation. Now, the hypertension evaluation is also integral to the follow-up of these patients. The guidelines will recommend doing right arm blood pressure, but as I mentioned earlier, it really depends on the vascular anatomy, so please keep that in mind and allow that information to be communicated effectively to the primary care provider so they're also checking blood pressure in the correct arm. There is a role for ambulatory blood pressure monitoring, as well as the role for exercise assessment of hypertension, which we'll talk about a little bit later. And then comes the question about screening for intracranial aneurysms. So before I get into specifics on hypertension and screening for aneurysms, I think it is important to understand that a lot of these patients that have intervention have a sensation that they are fixed and cured, and that is definitely not the case. This is just data out of the UK, retrospective study of over 800 patients that were followed up for 27 years. And what they found was very interesting. This is a graph looking at freedom from reintervention and over the years from coarctation repair. And the dashed line on top is freedom from surgical reintervention, which shows that there's reasonably good freedom from surgical reintervention. But what's important to note is that any intervention, including surgical or catheter-based intervention, were seen in about 50% of patients by the age of 50 years. So when we're following these patients, when we're communicating this information to the patients themselves and to the primary care provider, it is important to let them know that the need for reintervention in the future is high, and we are we are following them for a reason, and they do need interval follow-up imaging with the appropriate modality to look for this recoarctation or other reasons why intervention may be required, be it either aneurysm or pseudoaneurysm. So I'll touch briefly on cardiovascular outcomes. Mortality is always a very important outcome for us to discuss with our patients. So in this same study, they looked at survival of patients that had repaired coarctation, which you can see is a solid black line, and compared to the general UK population. And what they found that there was a reduced life expectancy, not unexpectedly, for patients that have aortic coarctation compared to an age-matched population, and noticing the decline really becoming more evident in the third decade. And which is important, because when we look into what these patients are dying of, it's primarily cardiovascular disease. So this is that same UK data, as well as I've incorporated some of the data from the Concourse study out of the Netherlands, which was prospective, about just under 1,000 patients. And when we look at this cohort of patients, they were followed anywhere between 9 to 27 years. And what we found is that the median age of death was sort of in the late 40s, but the majority of causes of death were cardiovascular. And I can break that down for you later if you like, but cardiovascular cause of death is the leading cause of death in patients with aortic coarctation. And when we look at, well, what were these events? Coronary artery disease, some type of stroke or TIA, thoracic abnormalities, so either aneurysm or dissection, thoracic aorta. Arrhythmias, hospitalizations for heart failure also occurred, endocarditis, and cardiovascular death. And in the Concourse group, they found about 21% of the patients had some type of cardiac endpoint. And that's only in the 9.5 years of follow-up that they had for them. So there is a high burden of cardiovascular events in this patient population. When they plotted it out, the risk of cardiovascular events against the age in years, you can see that it's almost a linear increase in risk. And when looking specifically at type of event, you can see here they've colored in each type of event and the yearly risk in percent over the age of the patient. You can see arrhythmia was very common and increased significantly as patients became older, as was presentation with aortic complications, so some type of vascular complication. So at the end of the day, these patients have a reduced life expectancy and a significant burden of cardiovascular events. What was also very interesting out of this same Concourse data is they found that the presence of left ventricular hypertrophy as evaluated by echo using our standard definitions of mass index to body surface area was predictive of cardiovascular events. So this is where having patients that have evidence of LVH, they're going to be higher risk for developing events likely, and as clinicians, we should be targeting risk factor prevention at them. So LVH by echo can be helpful. So when we're talking about the role of our follow-up, we're looking for indications for reintervention. We are looking for vascular complications at the site. It's important for us to evaluate for the development of cardiovascular outcomes, primarily hypertension, and doing our best to do other risk factor modification. So I'm going to talk a touch about hypertension now. The management of hypertension in patients with coarctation is going to be similar, or the definition of it is similar to the general population. So whichever society you are a part of, the definition of hypertension may be slightly different, but in general, pressure is greater than 140 and 90, although with ambulatory blood pressure monitoring, that definition or that cutoff is a little bit lower. The causes of hypertension can include residual obstruction, but there is also endothelial dysfunction. So it's important to remember, and your patients should know, that even in the setting of a completely removed coarctation, so no residual obstruction, they do have endothelial dysfunction and are predisposed to hypertension. And then the question becomes, well, what's the best way to diagnose it? Are we doing office blood pressures? Should they be doing home monitors, ambulatory blood pressures, or exercise testing? When we look at the guidelines, the American Heart Association recommends resting blood pressure measured in both upper and lower limb in adults, and to consider using ambulatory blood pressure monitor. The European Society recommends ambulatory blood pressure monitor in the right arm, and providing a lower cutoff, which would be in keeping with using that particular technique. And the Canadians, because the Canadian guidelines most recently are more focused on intervention, don't specifically address this. But I think it does raise an important message, is that post-repair prevalence of hypertension is very common. But resting blood pressure can underestimate the presence of hypertension. And so the sensitivity of an resting office blood pressure was less than 50% for picking up hypertension in patients with coarctation when compared to ambulatory blood pressure. And so they found that in general, resting office blood pressures would miss about a third of coarctation patients that truly had hypertension. So currently, 24-hour ambulatory blood pressure monitor is considered the gold standard for diagnosis of hypertension. So I have incorporated this into my care for these patients, and I think the guidelines are moving towards recommending that specifically for evaluation of hypertension and coarctation. And the take-home message, though, is that resting blood pressure alone is insufficient to evaluate patients for hypertension. Now, there are determinants or people that are higher risk for developing hypertension in the setting of coarctation. Those are typically going to be seen as male patients, patients that had an older age at repair, if there's any evidence of residual obstruction, or patients that have arch hypoplasia. So we should be particularly look particularly for hypertension in those groups. Now, exercise testing has been somewhat controversial. An exaggerated response to exercise, or so a hypertensive response to exercise, would be a systolic blood pressure in men greater than 210 and in women greater than 190 millimeters of mercury. In the general population, it was found that exaggerated blood pressure response to exercise can be predictive of hypertension development, future death from infarction, cardiovascular events, and angiographic evidence of coronary artery disease. And so when we look at, well, what do the guidelines tell us about exercise testing? The AHA says that exercise testing should be used for the evaluation of hypertension in adults who exercise, which seems reasonable. The Europeans say that the significance of isolated exercise-induced hypertension is a bit of a matter of debate, and the Canadians haven't addressed this yet. And so I think what's important is there is some literature that's growing showing that in patients with coarctation in the aorta, hypertensive response of blood pressure to exercise may be predictive of the development of hypertension in the future. And it is observed in patients that have residual obstruction. We know that post-repair, over 40% of patients with coarctation will demonstrate a hypertensive response to exercise, and it's really knowing what to do with those patients after we've identified it. And when we look specifically at patients with coarctation who are baseline normotensive at rest, about 35% will have a hypertensive response to exercise. So the Concourse study out of the Netherlands looked specifically at exercise-induced hypertension in about 670 patients with coarctation. Average age was about 24 years. Most of these patients were repaired surgically, so younger, no evidence of residual gradient in this group, and about a third of them were on medical therapy. So in this recent publication, these patients all underwent treadmill exercise testing. And for patients that had resting normotension here, what they found was about 35% had that hypertensive response to exercise. And then on their follow-up, so these patients were followed up for about 10 years, about half of those patients went on to be diagnosed formally with hypertension, compared to patients that had no evidence of hypertensive response to exercise. There was still a good number of them that developed hypertension over the follow-up, but not as many as the number of patients that had exercise-induced hypertension. So I think in patients with resting hypertension, the finding of hypertensive response to exercise probably doesn't add a ton to care. In patients who are normotensive at rest, the hypertensive response may be helpful to predict future hypertension. So the authors of this particular paper felt that the greatest impact of exercise testing is probably in normotensive patients that have hypertensive response, because we may tailor our follow-up to be more frequent for these patients, but it is still a matter of debate. But just to summarize some of the findings about hypertension and coarctation, it is important to treat residual coarctation if it's there. Medical therapy for hypertension in patients with aortic coarctation is the same as regular hypertension guidelines. But evaluation for the development of hypertension really should incorporate 24-hour blood pressure monitoring if possible, and exercise testing can be considered. And as I mentioned earlier, hypertension can be a marker of residual or recurrent coarctation. I'm going to touch briefly on coronary artery disease. There's two studies I wanted to talk about. It was felt for a while that coronary artery disease was more common in patients with coarctation. There were two larger studies that looked at patients with coarctation and used controls. The study out of Canada had about 750 patients. Median age was 31 years, and they compared them to a control group of patients with ventricular septal defects. They found that there was an increased incidence of coronary artery disease in patients with coarctation, but it was not independently predictive. So coarctation did not independently predict coronary artery disease when controlling for age and other risk factors. Another more recent study out of the US looked at about 650 patients, median age slightly older, about 36 years, and they compared this group of coarctation patients with that of a control group of tetralogy of Fallot, and found that there was no statistical difference in the presence of coronary artery disease between groups, especially not when controlled for the other cardiovascular risk factors. So I think what's the takeaway message in coronary artery disease and coarctation is that the risk of coronary artery disease and coarctation is similar to an age-matched population when you adjust for risk factors. There's no clear independent association of coarctation and coronary artery disease when you control for hypertension, dyslipidemia, diabetes, male and age. And so as physicians and care providers that are following up these patients, we really should be aggressively doing modification of risk factors. So encouraging exercise, no smoking, managing blood pressure, checking lipids. Now I'm going to touch briefly on intracranial aneurysms. I think there's been in the literature a very clear concern and association between the presence of aortic coarctation and intracranial aneurysms here. And this is just a nice picture I found from a case report demonstrating both. The prevalence of intracranial aneurysms in patients with coarctation is reported around 10%. There is some lower incidence or prevalence reported in series of about 0.6%, but these are large, hospital administrative databases that weren't specifically screening for it. So I think right now the best data we have is saying that the incidence or prevalence of coarctation aneurysms in patients with coarctation is about 10%. And this data comes from primarily the US, but there is data from Mayo, two publications they had screening MRAs in patients that were adults with coarctation in the aorta, median age of about 40, early 40s to mid 40s. In both of these publications, they had about 100 patients in the study and found a 10 to 12.9% incidence of intracranial aneurysms. In the more recent study comparing patients with coarctation and bicuspid valve, the rupture was 2 out of 20, although I don't know that we can really tell much from such a small number of patients. There was some data out of the UK looking at screening MRAs as well in patients over the age of 16, but the median age was a little bit older, about 29. They had over 100 patients and again found about a 10% incidence or prevalence, I should say, of intracranial aneurysms. The median age for patients with the intracranial aneurysms was older, was 37, and they found hypertension to be more common in patients with intracranial aneurysms. There is another study by Cook looking at CT as a screening tool for patients with aortic coarctation and found in their patient population of only 43 patients that the incidence of intracranial aneurysms was about 11%. So there's several studies that were dedicated specifically to look at prevalence of intracranial aneurysm, and that number seems to be around 10%, and that's where it comes from. So the trouble with intracranial aneurysms is that we always worry about the risk of intracranial hemorrhage and subarachnoid hemorrhage, but the risk of hemorrhage is uncertain in coarctation patients. It was a national inpatient sample database from the US looking at admissions to hospital. It had well over 17,000 patients and found that the incidence of intracranial hemorrhage was 0.9%. A similar type of study out of the UK looking at over 11,000 patients found that the incidence of intracranial hemorrhage was 0.3% with a risk of about 0.15% per patient year. In that particular group, they were able to say that patients with and only one of those people in the UK group had a known intracranial aneurysm when they presented with an intracranial hemorrhage. The other patients did not have a known aneurysm because typically they didn't have any data on who was screened. They did a multivariate analysis from this UK data and found that really hypertension was the only risk factor they could identify for intracranial hemorrhage. We also have data out of the Concord registry in the Netherlands with just under 1,000 patients. They followed them up for about 9 years and found that the incidence of intracranial hemorrhage was 0.2%. So it's all low, but we do see it varying depending on where we're looking. With respect to intracranial aneurysms and hemorrhage, when we looked at who had the intracranial hemorrhages, well, the median age in the studies that I just showed you was anywhere between 23 to 29 years. The mortality, though, was quite high. About a third of these patients that had an intracranial hemorrhage died. And of the people who survived, about a third of them ended up being discharged to a nursing facility, so not necessarily able to go home and functional to what they were before. So although intracranial hemorrhage is not particularly common, it may be devastating. And I think this is where we run into the trouble of, well, who we should screen. Typically, screening is done with MRI of the brain, but there's really no clear data on who and how often to screen. We don't know if we should do this in hypertension, in history of headache, pediatric, adults, and how often our repeat interval should be. When looking at what the guidelines say about screening, the American Heart Association says it's reasonable to screen, but don't really provide a lot of detailed information about who and how often. The Europeans say that imaging is indicated when patients develop symptoms or have a clinical manifestation of an aneurysm, but they do not recommend routine screening of asymptomatic patients. And currently the Canadians are staying out of it. So I did find an interesting cost analysis looking at would it be cost effective using a willingness to pay model of about $150,000 for quality life year gains, so similar to what dialysis would be. Would it be cost effective to screen these patients for intracranial aneurysms? And they presented a screening strategy. You can see here the estimated total deaths on the left-hand side, and then the screening strategy that they proposed. So no screening would have an estimated number of deaths around somewhere between 150 to 200 deaths. If patients were screened at 10 years, at 10 and 20, at 10, 20, and 30, or 10, 20, 30, and 40, you can see that the anticipated number of deaths from intracranial hemorrhage or subarachnoid hemorrhage would be reduced. The red bars are death from prophylactic treatment of those aneurysms. So you see that would go up as we do more screening. But overall, it was felt that using their model based off of the data from the studies that I had showed you before, that a model where screening the patients at age 10, 20, and 30 would be considered cost effective for preventing or extending life, preventing subarachnoid hemorrhage at that cost of about $150,000 per quality life year. And so we're still left with not a lot of clear data about what to do. Further studies are needed to look at the risk of intervention in this group and the long-term follow-up. But given the risk of adverse outcomes, I think screening is reasonable, but needs to be patient-centered, and you need to discuss this with the patient. I think, though, it's also been demonstrated it is really paramount to manage hypertension aggressively in these patients. I will talk briefly about follow-up for reproductive health. It's important to discuss contraception options with our patients. If patients have coarctation and are hypertensive, you may want to use non-estrogen-based methods. Preconception counseling is always very important to discuss risk for both mother and fetus. Typically, coarctation is considered a WHO class 2 to 3 risk for 10 to 19% adverse maternal events typically quoted. A new recent study from ROPAC showed that in about 303 patients with coarctation going through pregnancy, the MACE event rate was lower than that. And so with more data, the risk of pregnancy in patients with coarctation likely is going to be a little bit more clear in the future. But we do need to tailor this to our patient. And in patients who are pregnant, they do require close follow-up and monitoring of their blood pressure. So I'm going to just skip to the summary here. Coarctation is a lifelong illness, and care needs to extend beyond initial intervention of the lesion. It requires lifelong follow-up. We know that about 50% of patients are going to require some type of reintervention by the age of 50. and there is early mortality that has been driven by cardiovascular complications. Follow-up is typically comprised of screening and management. Physical exam, as I mentioned, is important. Office blood pressure is helpful, but ambulatory blood pressure, I think, being more helpful in this patient group, as well as considering the use of exercise blood pressure. Imaging typically done, screening with echo, but preferred to do cardiac MRI or CT to look at the site of coarctation, and to consider screening in patients for intracranial aneurysms. So how should we follow people up? Well, if they have no residual coarctation, I think it's reasonable to see them every 1 to 2 years. I tend to do 24-hour blood pressure monitors every 2 years and ask them to follow up with their primary care provider in the intervening time. I will do a transthoracic echo every 2 years, cardiac MRI or CT every 3 to 5 years. Exercise testing is a little bit more controversial, but I do it regularly. And I have begun practicing doing MRIs of the brain at 20 and 30 years for assessment. So all of these patients require follow-up lifelong. We do have to aggressively monitor and treat their cardiovascular risk factors, and we need to educate our patients and primary care providers. So with the remaining time, I'd like to open it up for discussion, because I think that this is a topic that has a lot more work to do to help clarify how we should be managing these patients.
Thank you so much, Robin, for an excellent and very comprehensive overview about aortic coarctation, which is considered being a simple defect, but as you told us, it is not a simple defect. It's a very complex defect. Actually, it's not a benign disease to be born with aortic coarctation. Are there any questions from the audience? We can extend the session a little bit, because it's my mistake, because my Swiss watch was 5 or 10 behind. So I need a new watch, but not the Swiss.
You need an iPhone.
Okay. So Dr. Henry Kafka, I just noted that in the ACC guidelines 2018, the recommendations define that the significant Doppler gradient as the mean Doppler systolic gradient across the aortic coarctation is defined as high of 20 millimeters of mercury. Are there any comment about that?
Yeah, so we do use the mean Doppler gradient. So I think similar to the peak-to-peak cath gradient. In general, I would be hard-pressed to send a patient for intervention without performing a cath first. So I do use the echo for a screening tool, as I mentioned. But typically, if the gradient's present of about mean of 20, but there's no evidence of a diastolic tail, I would then proceed on to doing some type of imaging test, be it either MRI or CT, to look to see if there's imaging evidence of a narrowing. And then if I was concerned about it, if the patient was hypertensive, I would move on to doing a cardiac catheterization.
Personally, I put a big question mark about this recommendation, because the simplified Bernoulli equation is a simplified equation of a very complex formula.
Absolutely.
And the simplified Bernoulli equation only applies to a discrete stenosis, but you cannot apply the simplified Bernoulli equation across a tube graft or a descending aorta, because the measures are completely wrong, as you also told us. Very nice. So actually, I go with the physical exam and the diastolic tail, or diastolic forward flow in the abdominal aorta. That's a very sensitive sign for a hemodynamically relevant aortic coarctation. There's a question from Dr. Carlos Guerrero. A great talk. What would be your approach for aortic coarctation, moderate or severe, in patients with residual significant aortic coarctation? Should one be expectant with aortic regurgitation in coarctation patients?
So I think it's an area that is challenging because when we get very prescriptive about the number of, or the millimeters of mercury of stenosis that would require intervention, you make a very good point that in patients that have aortic insufficiency, or even in patients that have large collaterals or LV dysfunction, that that gradient itself is probably not reliable. to define true aortic coarctation. So in those patients, I think having imaging evidence of that 50% stenosis at the area of coarctation can be helpful. In patients that have physical exam findings of a blood pressure drop may be helpful. And also in patients that are have hypertension on treatment. So I guess to put it another way is if I had a patient with moderate or greater aortic insufficiency, evidence of a more than 50% stenosis on imaging of their coarctation who are hypertensive, my threshold for intervening on that coarctation is going to be lower than that 20 millimeters of mercury that's typically discussed. And so I think the Americans talk about having a 10 millimeter mercury gradient cutoff. I think that's reasonable. Again, we need to take it into the context of our patients. But in the setting of hypertension and that 50% stenosis, I think it would be reasonable to intervene, especially if a lower risk intervention like a catheter-based procedure is possible.
Yeah, I agree. There's an indication for an intervention, but the question is, what's the sequence? What do you address first? Do you address first the aortic regurgitation and then the aortic coarctation, or the other way around? Or do you do both at the same session?
I guess it would probably be the least risky procedure first. I think that if you can do a catheter-based intervention on the coarctation, that may be a reasonable way of starting. I don't know that there's any clear evidence here, but I think it needs to be a discussion with the patient. If I had a young woman with moderate or greater aortic insufficiency that was thinking about getting pregnant, I might intervene on the coarctation first, doing a catheter-based procedure. If they have to go for surgery either way, then likely both lesions at the same time.
Yeah, so I agree. So I can remember 3 or 4 patients in Toronto in the last 5 or 6 years. So actually, this is also our approach. Also, if the aortic coarctation is amenable to an intervention, do a balloon dilatation stenting first, then followed by open cardiovascular surgery to replace the aortic valve. There's a comment from Dr. Naumann. My question regarding LVH and its outcome in coarctation patients. Any comment regarding degree of LVH and associated diastolic dysfunction associated with more poor outcomes as degree of LVH increases?
That's a good question. I think the study that I showed you out of the Netherlands looked specifically at the presence of LVH using the cutoff of 95 grams per meter squared for women and 115 grams per meter squared for men. And they didn't specifically look at diastolic dysfunction in there. I think one could assume that the worsening diastolic function you have, the worse outcome you'll have, just because you're going to be seeing that in more complicated patients. But from the data we have right now, it's just presence of LVH, looking at increased risk for intervention.
No, correct. I agree that the role of exercise testing is debatable, and even the role of routine screening for brain aneurysm is very debatable too. In Toronto, at the Toronto meeting, we had actually 2 debates about this topic about the aortic coarctation and the association of brain aneurysm. I guess it was in 2012 and 2018. And we had a vote, and then there was the consensus that actually routine screening doesn't add to the management if the patient is asymptomatic, if the patient does not have any symptoms. So the question is, if you routinely screen the general population, in how many individuals do you find then a small aneurysm? And the question comes up, so what do you do now?
Right. Which is part of that discussion and consent process for screening. If a patient doesn't want to know about a small aneurysm that we want to intervene on, then you might not want to screen for it. I think that, the jury's still out on this, but in people that are hypertensive and people with headaches, I think it's reasonable. I've started having discussions with my patients once they transition at around age 18, and we'll typically do a screening MRA in them after we discuss it. I may change my practice as the literature changes and grows in the future, but right now, for people that agree to it, I have started doing it, and I guess we'll see what comes of things.
I think that's a reasonable approach. I don't routinely screen if the patient does not have any symptoms, no headaches or migraine, but as soon as there's any suspicion of intracranial process, and I do an MRI. Because as the older you get, then you're also getting more aware of the cost effectiveness. So what does it cost and what do you get? And even that's also the Swiss approach. And the Swiss are born as accountants. They also think, oh, what do I get? Yeah, that's true. What do I get and what do I pay for this? So that's the reason why we frequently reject proposals from the government or the parliament, because they make decisions which doesn't bring anything. Okay, any other questions? I think what's also important question is also a role when we see these patients in our daily clinical practice, that we actually recommend routine screening of the first-degree relatives. What they see is we see patients with aortic coarctations, but their brothers or sisters haven't been screened for a congenital heart defect, for instance, for bicuspid aortic valve. I think that's also important that all the first-degree relatives should be screened for a congenital heart defect.
So I've typically done that for anybody with a bicuspid valve. I haven't done it for isolated coarctation, but that's an interesting point you bring up.
Yeah. Are there any other questions or comments? Okay, yeah, thank you very much, Robin, for this very interesting and comprehensive review of a daily clinical problem we face every week. And we need just to, you reminded us that aortic coarctation is not a benign disease. It has a lot of complications with reduced life expectancy in the overall population.
Absolutely.
So I close the session here. I wish you a great weekend. Have a good afternoon, good evening, or good morning. And we will meet next time again, next Friday. Next Friday will be a speaker from Spain. Okay, have a great day. See you next week. Bye.
Bye.